Hi everyone, Rachel and I will be doing our case study on pediatric dysphagia.
Okay, so the patient we're going to talk about today is a 6-month-old male named Gerber.
Our patient was born prematurely at 24 weeks via cesarean section. He had a birth weight of 1.6 pounds and was admitted to the NICU for about 5 months until he was discharged home. His developmental milestones are delayed, and as far as surgery goes, he has a G-tube placement with fundoplication, which we will talk about later.
Okay, so a little background about our patient's medical history that includes GERD, epilepsy, brain bleeding, periventricular leukomalacia, which is a form of white matter injury, rickets, which is a softening and weakening of the bones, apnea, and dysphagia. His medical history also indicates that there was a barium study swallow done after his birth that revealed there was aspiration of liquids. Therefore, they placed a G-tube with fundoplication. Fundoplication is a surgery for GERD. The recent barium swallow study revealed that there was no aspiration of puree or thin liquids. They kept the G-tube so that the patient could receive vitamins and stool softeners, and now the mother is introducing puree by mouth via spoon.
After evaluating our patient, we reported that he has oropharyngeal dysphagia. The following characteristics were observed during our evaluation. He had oral motor weakness, so he was unable to remove food from spoon with his upper lip. He had reduced bolus formation due to lingual weakness. He had anterior spillage due to reduced labial seal, and he was pushing food outside his mouth, and this was due to frontal backward lingual movement beyond the lips. However, when food is presented to back of the mouth, he was able to trigger a pharyngeal swallow. He also presented oral hypersensitivity, so meaning he had reduced stimulation to oral cavity. So for example, our patient had an inconsistent response to food via spoon presentation.
Okay, so the duration of treatment for our patient will last 180 days, and it's going to be 2 times a week for 30 minutes each. Our long-term goals will consist of the patient being able to accept and tolerate pureed foods and thin liquids for his consistent everyday living activities. The patient will also be able to obtain an age-appropriate feeding technique for PO intake.
So we are going to show short-term goals step by step and then give you an example of each. So for our first short-term goal, it will read, patient will tolerate oral motor exercises to increase lingual jaw movement, lingual elevation, lateralization, and strength, upper lip movement, and labial seal to reduce anterior spillage and reduce carriage of tongue beyond the lips during feeding, with 80% accuracy, giving multisensory cues as needed. For the first goal, a clinician can use a variety of equipment, which include a silicone oral motor stimulation device that is placed on the index finger and used to stimulate around and in the mouth to elicit movement and reflexes. Clinician can also use the nuke brush, which can also be used inside the mouth for similar purposes. Last, the clinician can use a hypoallergenic plastic tube used to elicit rotary movement of the tongue and chewing. For the silicone oral stimulation device, I would just go to the child and touch their upper lip and just kind of do light massages around their mouth, under, over the lip, and then for inside the mouth, instead of the tube, I have a straw right now, but I would have the child put in their mouth. If it's a baby, you do it for them, and you just go side to side, so it promotes tongue movement. And then for the nuke brush, I don't have it with me, but you would do the same thing as the straw, except it has the rough edges, so it would be more stimulating to the child.
Okay, so for our next treatment goal, the patient will consistently accept and swallow pureed foods when presented by spoon 80% of the time given multisensory cues. And for our third goal, the patient will tolerate 3 ounces of thin liquids with no signs of aspiration when presented by spoon with 80% accuracy, again given multisensory cues as needed. So for our feeding goal, we're going to be feeding the patient with thin liquids. So we have water here. What we're going to do is just place the spoon in the patient's mouth, and because there's a pharyngeal swallow that's elicited from the back, we're just going to push it a little in the back and let the patient swallow. And for our last goal, our patient will use their upper lip to remove the food from the spoon 80% of the time with tactile cues. Okay, so for the goal where you're going to give the patient pureed foods, you're going to want to just put the spoon in the mouth and then push down on the tongue and then just kind of scrape up a little bit and let the patient grab the food and remove it from the spoon. And then if necessary, you can even push down on the upper lip so that you... As a part of treatment, we also like to include parent education at the end of every session. This will ensure carryover of oral motor exercises at home as well. We also provide a handout that discusses the techniques and tips for GERD when feeding a child. This will assist the caregiver to ensure a safe environment for their child and practice techniques during feeding.
Thanks for watching, guys.
We hope you found it informative.